Welcome to the podcast. I'm your host, Jim Jorgenson, and today we're going to try something a little different. On our pod on infusion services, it actually generated a lot of interest. So we decided to solicit infusion-related questions from our audience, kind of in advance of this pod, and then let our infusion experts address the questions, kind of our version of Infusion 20 questions. And we did receive some great questions, and we won't have time to get to them all. But Dale Drizd and Erick Siegenthaler are going to tackle as many as we can get to in our time slot. So welcome, guys.
Thanks for having us.
Thanks, Jim.
Absolutely. Erick, you've been on the pod before, but Dale, this is your first time. So let's start with a brief overview of your experiences and how you got to where you are today. And let's go Dale first and then Erick.
Great. Thanks, Jim. Yeah, so Erick and I actually have similar experiences over the last 5 or 6 years. So we've been working together for a while, and it's been great. Erick is a true expert in this area, so it's been wonderful learning from him. But I'm coming previously from Freighter at the Medical College of Wisconsin. I spent about 8 years there running retail, specialty, home infusion, and PBM operations. We helped build the home infusion program from its inception over there, and obviously Erick was a huge part of that, and give all the credit to him for building that program. And it's been a tremendous success, and we were at the right place at the right time with where our infusion space is today. So it was really great. Part of that, I was with the Walgreens organization. So I spent most of my career there, pharmacist by trade, spent some time in Walgreens retail locations, and then moved to the corporate office in Deerfield, and did a lot of different national pharmacy programs at the corporate office, including technology, innovation, and anything that kind of touched our pharmacy operation. So my background and experience is probably a little different from what we normally see when we talk to some of the health systems and hospitals out there. I didn't do a traditional residency, but I say I cut my teeth in the real world while everybody else was in their residency program. So I joke, but it's great to be here, and looking forward to talking more about the infusion landscape.
Awesome.
Thanks, Dale.
Yeah, thanks, Jim, and thanks, Dale. So I'm Erick Siegenthaler, Senior Director for Infusion Strategy at Visant. I've been with the organization for 2 years now, and as Dale mentioned, we're a package deal. Prior to my time here, I was at Freighter Health in Milwaukee, Wisconsin, where I oversaw implementing and growing our home infusion and ambulatory infusion suite operations there. So I've really enjoyed getting to know and learn more about other organizations, where they're at with their journey in infusion strategy, and really helping a number of organizations to get up and running and optimizing their programs. So I'm really excited to answer some of the questions that we got today, and continue to share with our colleagues across the nation.
All right, well, let's jump right into those questions. We have multiple infusion operations across our system between clinic sites and home infusion. How should we approach making this more connected in terms of more shared processes?
Yeah, I'll start, and Erick certainly weigh in here. We see this often across the clients that we service, and this is probably a national trend. The infusion services lines in major health systems and hospitals are pretty fragmented. Normally, you have really robust oncology services that include infusion operations in hospital-based space. And oftentimes, there are some ambulatory infusion spaces as well. Not so often do we see systems have home infusion capabilities as well as that. And so it is fragmented from a patient care perspective, depending on where you're at, who you're being seen by, what treatment you're looking for. And unfortunately, that makes it challenging for providers and patients to try to navigate the care that they're receiving. And so what's really important, and what we were trying to do for the clients that we work with, is help them create that centralized process to bring it all together. So look at your infusion services holistically. Look at all the assets and the resources that you have across your system, and bring it together. And what are those key areas that are the same for all of those different sites of care? And how do you centralize that process to make it easier for administrations on the provider side as well as the patient side? So creating a process where you centralize medication access, for instance, is really critical to make sure that you have that first step completed and really clean for the patient and claims downstream. We're talking about prior authorizations, patient assistance, benefits investigation, making sure which site of care patients can be seen at. Oftentimes we see now payers are steering patients away from more expensive sites of care into less expensive, like in the home or in the ambulatory suite setting. And so having a centralized team that can help you navigate those challenges and burdens is really important and critical to standing up a successful program and making satisfaction for providers and patients at the same time. Eric, what did I miss? What can you add to that?
Yeah, I would just say I would agree from the fragmentation standpoint is the key. Whether organizations do or do not have home infusion or alternate sites of care set up, I would say, historically pharmacy has been to some extent on the periphery of our hospital-based infusion services. And for the alternate sites of care, we're seeing organizations recognize white bagging site of care and the opportunity and pharmacy being more involved in those alternate sites of care. So I think it's, understanding some of those. Dale talked about centralized medication access services, prior authorization, patient access, et cetera, but understanding who is ordering infusions. It's not always the same as maybe the same groups as maybe you look at from a specialty pharmacy lens, and understanding what challenges are they facing within those clinics, whether it is around prior authorization or what challenges are they having when they're working with outside infusion providers, and how can you support that more effectively? And then again, to Dale's point, how do you coordinate if there is a denial instead of providing rework for those clinics and providers, which can be awfully frustrating and a significant amount of administrative burden? How do you coordinate to keep those services internally between your levels of care, really trying to reduce friction in that process?
Thank you. Next question. We're thinking about creating an infusion program and are interested in what kind of infusion-specific software considerations we should be thinking about relative to our EHR.
Yeah, I can start on this one. So, I mean, I think many organizations are interested in trying to leverage their existing EHR from a home infusion standpoint. And from our experience and the ways that we work with organizations, we can really help to create those workflows and integrate between different disparate systems. I think that's a challenge and a gap in the home infusion world, but I think that is being closed. But ultimately, I think to the question of like, what should we be thinking about is one, likely looking at different software, separate software from your system's EHR or from your retail pharmacy standpoint. That can be a challenge. But I think, again, certainly something that we can help to navigate and support, as well as looking at how can you leverage tools that are within your EHR. We talked about centralized medication access, for example. How do you pivot? And, I often use the term Frankenstein, but Frankenstein, different functionalities within your health system EHR, so you can improve communication, transparency, and process, and often find efficiencies in clinical documentation as well.
And I think I'll add the EHR vendors that are out there today are taking notice of home infusion specific workflows. It is different than traditional infusion workflows that you see in the hospital-based space that I think most of the EHRs were built for. So ultimately today, if you're going to get into this business, you do have to select another software vendor in order to help you support the billing and the reimbursement side of how that workflow operates. But to Erick's point, our team and what we've seen with our clients, we're able to help bring those together cohesively so that you're working within that EHR to the extent possible to make it as seamless for patients and providers while leveraging the other software in order to unlock the functionality that's needed to actually operate the business. But in the future, I think these EHRs intend to build some of this functionality and make it a little bit more seamless, but that hasn't been the case to date.
Excellent. Next question. We have an infusion program but we'd like to improve our infusion prescription capture rates. Any suggestions on how we might accomplish this?
Yeah, I'll start. Can I start with this one, Dale? So, I mean, I think this is key. Any pharmacy leader has probably said the same thing from their retail specialty pharmacy lens as well. But I think the key thing to call out for infusion is we already talked about how it's fragmented. So retail specialty pharmacy is less fragmented than infusion. So just I think recognizing that. And understanding that infusion patients are like a portion of specialty patients. So it's relatively there are a lot of patients that need infusion, but it is less frequent than patients that need retail prescriptions. So I think you cannot lean on we are the same system. We will be able to get all of the business within the system. We talked about some of the EHR tools and how can you leverage that to help drive and reduce the friction to capture prescriptions. Really, from our lens, we look at we strongly recommend hiring good staff that are able to liaise between your clinics, your key clinics, and your pharmacy. There's an education component into that to understand like what is needed from infusion, because many providers may order infusions a handful of times a year. And frankly, that's just not something that occupies a lot of space in their brain. So helping to support them, just like any external vendor probably would wish they could get the access to your providers doing, but to be able to help support that process, educate on what services can be provided, as well as like what services can be provided in the home setting and what options are available for patients can be really huge. And I think, again, that clinical documentation in the EHR and the transparency as well, find the pain points for the providers and really try to help fill those gaps can drive prescription capture in the infusion world. Dale, do you have anything to add to that?
Well, yeah, I mean, you hit it on the head. How do you make it easier for the provider and the care team, right? That's really what they're looking for. But it starts with service and outcomes, because the providers really, they care about how well is this going to treat my patient? Are they going to get treatment quickly? Is it going to be the least expensive option? And are they going to get better? Those are the things they care most about, is that patient. And Erick talked about this. Most patients that come in and see a physician, they have a pharmacy or their regular retail pharmacy needs. It's my pharmacy on the corner of State and Main, and they know what that is, and that's where they go for all of their things. In the infusion world, it's very different. Most people don't get infusion therapy. They don't have an infusion pharmacy. They don't have a provider that they go to, so they know nothing about the market. And really, they get educated that first time that they need that treatment. And usually it's the provider or the care team or case managers that are providing that education. And if you want to increase your capture within your system, it's not as simple as Erick stated, it's just saying we have one, use us. You have to have that service element to it. It has to be better for the patient. It has to be, as good in the price or better, and it has to be better for the provider. So what kind of administrative burden can you remove from the provider, like centralized med access, prior authorization, patient assistance, in order to make it easier for them to want to use that service? And so it becomes second nature. They know, I have this wonderful program here. We have, Joe, our home infusion director that services us, that's on, I can get a hold of him whenever I need it. They've got support at home and they've got support in the suite setting. They're going to take care of you financially. When providers see that happening, it makes it very easy to recommend. And that's when you start to see that capture really ramp up and increase, because they don't want to use other options. They know you're the best, and it's the best for everybody, the patient, the provider, and the system as a whole.
Yeah, so unlike Field of Dreams, if you build it, they won't necessarily come unless they do all the things you guys just mentioned. Super points.
Exactly.
Question. We are thinking about expanding our existing infusion program. What are some of the key things that we should be considering?
Well, I'll start. There's obviously, and this takes a lot of planning and assessment, and data is key here. So you really have to be able to have the knowledge to look and see what's happening within your universe. And I talk about data because what we see across the country, when you think about infusion, there's a lot of leakage. There's a lot of business that gets prescribed, but then gets fulfilled outside of health systems. And oftentimes that's invisible to the health system because they don't necessarily have a similar defined process. Erick talked about leveraging the EMR in a similar way. Most of the time we don't see that. And so there's sometimes, providers are faxing forms. Some give it to nurse liaisons from other companies that are in the hospital and they take it and run with it. There's just all these different ways that orders get generated and fulfilled outside of the system. And so data is key. What you need to do really before you get started is look at what's actually happening. What's the opportunity that you have within the infusion business? Is there opportunity on the specialty side? On the traditional side, is there a lot of, do you need to help support getting patients out of the hospital faster and give them a home option to free up bed space, helping patients get well faster, reducing readmissions? All those things come with building an infusion program, but you're going to want the data to support that you have the opportunity to do it. From there, you look at your assets and the facilities that you have. If you're going to do traditional infusion, you're going to need a clean room. So do you have the support or the space to be able to do that? Can you leverage existing? Do you have to build new? Then you're looking at your capital process and, what does it cost to build a clean room to fulfill? And then does that still meet the opportunity assessment that you've done? And can you be profitable within that business? And I'll tell you, almost every time, infusion is a very profitable business line. So supporting that for the system, both not just from a financial lens, but from a patient outcomes lens with some of the value-based care contracts that we've seen, it really helps to improve the financial success of the health system. But then from there, you really have to look at the efficiency of your operations. And so you're going to need to find experts in the industry that have run and operated home infusion business before, because it is very unique and it is nuanced and it requires a lot of coordination across the system. And so that's from the providers to the case managers to nursing to revenue cycle to payer contracting. You're touching more areas of the health system than you do mostly in any other business that you run. And so it does require a lot of planning and coordination in order to operate the business in the right way and get it set up and structured. So you get to that place where, what we talked about earlier, you have providers knocking on your door, dying to get in to use your services because you've done it so well. But it takes a lot of coordination, a lot of data to justify what you're doing. And really, that's what we see and how we help our clients when we come in. We have the expertise. I talked about Erick earlier on. I mean, he has started and grown a multi-million-dollar home infusion business. We have lots of resources like Erick and our team that help these clients and these systems to really streamline their businesses, help them grow them from nothing in those that have them, help them continue to optimize them in the best fashion.
Yeah, that's great, Dale. I don't know that I have much to add outside of like some of the soft stuff, which is just, you talked about some of the complexities of home infusion, but relationships. We already talked about clinics and trying to help them to understand what infusion is and how to access, but it's case management, it's managed care, it's revenue cycle, it's supply chain. Some areas that maybe pharmacy typically doesn't get super involved with. From an infusion lens, we do get much more involved with, and it's really valuable and really fruitful, frankly, not just for infusion, but for all pharmacy services to do so. So again, we can help you to navigate, like, who do you need to talk to? What are the questions that we need to be asking, and how can we support those key stakeholders to help them do their job and therefore help us do our job?
Yeah, and just to pick up on that point, here's a question that kind of drills into what you just said a little bit more, Erick. Infusion is a major revenue source for our system. What should we be doing to help optimize pharmacy-related revenue cycle elements for the program?
Sure. Well, I think we've got a really strong infusion team, but I think we've got an even stronger revenue cycle team at Visant. So Maxie Fremel and team. First of all, from a health system, pharmacy, infusion, revenue cycle standpoint, I've learned so much, and I thought I knew a decent amount. But I do think, again, understanding some of those key pieces within the EHR, EMR, in terms of how you are charging for medications and making sure you're getting reimbursed. Those are the things that her team is really expert at, honestly, and we work closely with their team on any project on that. But I think from an infusion standpoint, and a little bit more in my comfort zone, frankly, is just we talked about payer restrictions around site of care. We often see organizations, the fragmentation, I think, is what drives it. Either lose those patients because, hey, we got a denial and it's getting kicked back to the clinic. They're not sure what to do. Hey, guess what? There's an external infusion provider that showed up. Can you do this? Yes, and it's gone. So you just lost that revenue stream, which is for chronic disease states is generally an indefinite revenue stream, and frustrated the provider, and open Pandora's box, right? All these things. Otherwise, you're getting a denial, and the provider is saying, "Well, this patient's been stable for a long time. We don't want this patient to miss or delay their dose, so please just give it." So the infusion clinic may just give it, and you're left with the denial, with a write-off and bad debt, right? And that could be compounded because, once again, in this situation, these patients are on therapy indefinitely. So there's a couple danger points there that, from a rev cycle standpoint, pharmacy needs to make sure that they're integrated with, whether that is from like a charging and revenue cycle, like the back end rev cycle capture standpoint, but also from just a coordination of care, which we kind of call that front end rev cycle process, which is intake, that medication access services, and how do you coordinate the patient to the appropriate site of care. So I think those are critical elements, again, both from an infusion standpoint, but also from our rev cycle management standpoint.
Yeah, I'll just add, Maxi has taught me a ton in my short time here. And to echo Erick's point, that front end piece is probably the most critical and most important. So when we talk about that centralized infusion referral process, if you get that right, you get the right documentation, you get the right form signed, you get all that clean before you give any administration of an infusion, the downstream revenue cycle piece of it becomes very simple, and it's very easy because you have everything you need to get a clean claim. And if for whatever reason you do get a denial, you have all of the proof and documentation you need to, to go back and try to fight those denials. And that's something that Maxi is ingrained in us. And that's what we do. And that's why we focus so heavily on that centralized process, because it doesn't just support home infusion needs on the pharmacy side. This is something, if you create the right process and you're doing the auths for every infusion opportunity, this is going to support your revenue cycle across the board for the health system. And usually we see many millions of dollars of lost opportunity on the revenue cycle side, that just one drug can make millions of dollars worth of difference, one claim. So it really is critical to get those pieces accurate when you're building this business.
Yeah, and actually, I do want to add one more thing that made me think of is, I would say that most engagements that we partner with clients on, when we talk to finance, there's always a tinge of concern that if we provide alternate site services, does that open us up to reducing revenue in our hospital-based settings? And I think, again, working with Maxi and her team, the rev cycle team, to show like, both, one, there are services already leaving your organization today. Here's the problem, and you may not be able to see it from like a discrete data standpoint in your EHR, like Dale mentioned before, but also you may be writing off a significant amount of revenue or providing drugs for free through a white bagging program, et cetera. So if you're able to coordinate, there's really, frankly, a lot of synergies where ultimately at the end of the day, you're improving your system's revenue stream from an infusion standpoint and not damaging it in any way.
It's such an awesome point, Erick. And I'm glad you brought it up, because that's probably the one thing we hear all the time, right? Is you're going to cannibalize my very profitable hospital business if I create these ambulatory suites at a lower cost. And we have yet to see that play out. And we've also heard from some of the managed care partners saying they're worried about price parity. If they build these alternate sites, that it's going to impact their contracting on the hospital-based sites. And we haven't seen that come to bear either. So most of that is unfounded. And I would say most systems we see have capacity issues in their hospital-based spaces where they're, weeks out for scheduling patients. And so what having alternate sites does is gives you the opportunity to shift patients to where A, they want to be seen, but B, where it makes the most sense from an efficiency perspective within the health system to allow you to unlock that value of the assets you have in those hospital-based spaces. So you can take the more, critical patients that need it more immediately, or those patients that maybe the profitability is better there, and then open up your other sites for those that, like Erick said, we're probably going to leak anyways. If you told them it was 6 weeks away from an infusion, chances are they're going to try to find somewhere else to go in that time. And so at least you're able to maintain that business and it's ongoing. So losing that and trying to then capture that back is almost impossible. Once a patient's established somewhere else, it is very hard to move them, especially from an infusion perspective. They start to get to know those nurses. They know the nurse very well. They know how to get my vein every time, right? Those are things that matter to patients. And so you try to get them right away. So great point, Erick. Glad you brought that up.
Thanks.
They're really good insights, guys. One more here. We're in the process of designing a central service center for our system, which includes pharmacy and central supply. What should we be thinking about in terms of infusion service?
Yeah, I would say there's a lot. Dale mentioned before, looking at what type of services are you providing. You may be planning to build a clean room in your centralized service center already. And I think that's a perfect opportunity, frankly, to say, let's leverage this capital opportunity or the business plan around that and supplement it with some additional opportunity around home infusion. So co-locating some of those items can be huge. We look at, other organizations from a central services center are putting their specialty home delivery mail order pharmacy in those locations. You may be looking at shared staff and how do you collaborate effectively between those service lines. I think that's another opportunity. Similar with, if you are doing home delivery, shipping either using a courier or a common carrier, those are things that are going to be provided. And again, in efforts of not duplicating efforts and services, those are things that can be synergistic within a CSC. I would say also supply chain as well. Like you are going to be different from a retail pharmacy and home infusion. You're going through things like tubing and infusion pumps and all sorts of disposable supply items that are generally going to be supplied by your supply chain. So that can be a really great and effective opportunity to reduce space needs if you have a central supply chain setting.
Yeah, and we see a lot of systems include that supply chain side, that central pharmacy distribution within their CSCs. And that helps to unlock a lot of value that Erick was talking about just from a coordination perspective, but also when you look at drug pricing. So when you centralize it in that site, and Infusion is not immune to this, you are able to leverage the capabilities of drug pricing that your system can unlock, whether that's 340B or GPO pricing. But to be able to have it all centralized there, you can create workflows that make it very efficient and seamless across both your specialty and your infusion, because at the end of the day, a lot of those products cross over depending on what the payers want, whether they put it on the pharmacy or the medical benefit. But you also have economies of scale where these are a lot of refrigerated products. And so you can share a lot of redundancy for refrigerators and freezers and some of the other supplies and equipment that you need to support these businesses. But I'll say Erick's dead on with the courier or the mail process. Either things are going to the patient's home or they're going to other clinics within your setting, and you can certainly get economies of scale there as well. And to Erick's point, being able to leverage, the fulfillment of the medication when you're looking at like a specialty med on a take home or an infusion side is very similar. It's packaging the med, it's getting everything in order and sending it to the patient's home. You can leverage a similar assembly line to do that, which really will help you unlock a lot of efficiencies through that CSC. So that's something our team can help assist with. We do a lot of the Gemba walk when we look at the operations and what are the right ways to set up a CSC in order to make sure that, where do you need to be close to the delivery bay so that, you can get shipments out quickly and there's less steps for your team and all those things that you don't necessarily think of when you're originally setting it up by yourself, that you wish you had done, had an expert to say, yeah, you should probably put it here because you're going to save yourself 20 steps a day. And that makes a huge difference over time. And then the other thing I'd say is never underestimate the amount of space you'll need, because as we've seen with not only the infusion program, but specialty programs across the country, it continues to grow. And we don't see that stopping. When you look at the infusion market, a lot of the new specialty products that are coming out are injectable or infused meds. And you need to plan for that growth, and the space in the CSC is a great way to do it. You can have shelved space that doesn't cost a lot of money that you could grow into over time.
Thank you. Maybe a related question here. We have a specialty pharmacy program and an infusion pharmacy program. What are you seeing in terms of crossover and synergies for these programs?
Yeah, I think we touched on a lot of it. I would say one of the biggest is the medication access piece. So if you can have a team that supports the pharmacy and the medical benefit, prior authorizations, patient assistance, you could really start to unlock that centralized process for your system. And that's a huge key to pretty much everything, to capture, to revenue cycle, to your ability to service patients in the best way possible, provider satisfaction, patient satisfaction. Those are all good elements, along with some of the efficiencies we talked about. If you have both of those programs, there's a lot of efficiencies in what you're able to do with negotiations with drug companies, or product purchasing, or even rebates. If you have some of those conversations, there's a lot of different ways you can take it when you have a little bit more scale. And then to Erick's point, working with managed care has many benefits. I mean, in the traditional retail pharmacy sense, that wasn't a department that you normally worked with, because pharmacy contracting is very different from medical contracting. But bringing it together, Infusion almost forces your hand there. You can start to have the conversations about white bagging and some of the other brown bagging techniques that the payers are currently leveraging. And you bring those two teams together, you have a very strong clinical story. You can talk about the patient journey. A patient could start on a take-home med, and then they might be prescribed an infusion therapy if they fail that take-home med. And then if that doesn't work, they might be prescribed another specialty injectable, self-injectable, right? And so they could funnel in and out of these different sites of care. And so your ability within the health system to maintain that one patient view, regardless of what setting they're being seen at, is critical to patient success and satisfaction. So I think there's a lot of ways to leverage the efficiencies that we talked about, but just having that common EMR, that insight to be able to follow the patients holistically, really makes a huge difference.
Yeah, I think Dale touched on most of the pieces, and like he said, we've kind of had threads of this discussion throughout the conversation today. So I think I would add also, we see more complexity at times from different payers and how they're managing new medications that are coming to market. So is it covered by a pharmacy benefit or a medical benefit? Products that are coming out with like on-body injectors, or they're going from IV to sub-Q infusion or self-injectable. So, Dale mentioned that patient journey, but there's also like the drug market journey that we see. There's a lot of new drugs that are coming to market that are infusion, but there's also a focus from pharma on how do we make drugs more efficient and convenient for patients as well, to differentiate. So I think that's something that, coordination between specialty and infusion can be really critical as well. I do think that's something that's really key that Visant brings to the market, is the ability to understand both the specialty and the infusion market and how those two play together. Most clients that we're working with, we're engaged on both specialty and infusion, and I think we can find those synergies and help to guide organizations, whether it is optimizing existing services or implementing new services, and how do you coordinate between those two service lines to not create silos, but ultimately to be more efficient, be more effective, and at the end of the day, provide better patient care.
Well, that's fantastic. And I really appreciate you guys taking time out of your busy day today to discuss these questions with us. And I want to thank all of our audience members that submitted questions. So Thanks again, guys, and thanks everybody for listening.